So, good morning to all of you. I think even though our session is supposed to start at 11, I thought we will start the preliminaries so that we will save time. So, this session is on pattern strabismus. So, we thought most of the general ophthalmologists, the word pattern strabismus or thinking about pattern strabismus would be they may think it's a very, very bizarre picture, but we want to make it a bit simplified so that even general ophthalmologists understand what is pattern strabismus and at least how to deal with it. So, if not for the surgical and medical management, at last they will have an idea of what the term pattern strabismus is about. And so, in this session, we have got 4 speakers, and we are fortunate to have the keynote address by our eminent pediatric ophthalmologist and strabismologist, Dr. Kaushik Murali from Shankara Eye Hospital, Bangalore. So, you know the quality of work, the quality and quantity of work on pediatric ophthalmology and strabismus they are doing. And our special welcome to Dr. Kaushik Murali being the guest speaker of this session. So, the first talk on this session is overview of pattern strabismus, which myself, Dr. Sarasanamam, previously Director RIO and currently at Chaitanya Trivandrum. And with me are 2 of our colleagues from Chaitanya. One is Chaitanya Warrior from who is working at Chaitanya Tiruvalla and Kottayam. And Dr. Rashmi Bhaskar is our pediatric ophthalmologist at Trivandrum. We are sharp on time. So, overview of patterns. In 5 to 6 minutes, we'll see what this, we will have a bird's eye view of what is pattern strabismus. So, you look at this definition, this word incompetence. Incompetence in squint, it means that if you look at the deviation of the angle of the squint, in various cases it will be different. That is what the word incompetence means. So, if you look at the definition of pattern strabismus, it is a situation where there is a presence of significant deviation in the angle of the squint from up gaze to down gaze in patients who present to you with an ESO or exotropia. Or this may also happen in a situation where in the primary position, apparently there is no squint in the primary position, there is no horizontal squint. But in up gaze or down gaze, there may be a significant incompetence. So, this is the situation or what is pattern strabismus. So, when do you, in a strabismology clinic if you are sitting, or in the general ophthalmology clinic if you are sitting, when do you suspect a pattern strabismus? So, any patient presenting with an ESO or exotropia, if he or she has a chin up or down position, or as I said in the definition, in the primary position there is no, if you see the patient there is no obvious squinting, but the patient has got a chin up or down position, you suspect that the patient may be having a pattern strabismus. So, if you look at the incidence of alphabet pattern, so this is alphabet strabismus, pattern strabismus, where pattern would be the more ideal term because you may rarely have pattern strabismus which may not follow the alphabets. So, the pattern strabismus would be the more ideal term. And if you look at the incidence of pattern strabismus, the alphabet pattern strabismus is seen more in esotropias than exotropias. And amongst the common alphabet patterns that we see between the V pattern and A pattern is more than, V pattern is more than A pattern. So other than the common V pattern and A patterns that we see, rarely you may see a Y pattern, which is probably a subtype of V pattern, where there is a relative divergence which is more in the upgaze. Or you may get an inverted Y pattern or an lambda pattern, which you may consider as a subtype of A pattern, where there is a relative divergence more in down gaze. Or you may also get rarer X patterns, where there is a relative divergence both in up gaze as well as in down gaze. Or a pattern like this, which is called a diamond pattern, where there is a relative convergence more in up gaze as well as in down gaze. So the various patterns can be there. So there are still rarer other patterns and pseudo patterns. So these are the usual alphabet patterns that we come across. So if you, in alphabet patterns, in pattern strabismus, if you look at the associated features, some patients with V or Y pattern have an inferior oblique overaction, and patients with an A pattern or the inverted Y or lambda pattern may have an superior oblique overaction, or patients with the rare X pattern may have an overaction of both the superior oblique and inferior oblique. So in cases of pattern strabismus, many a time we find that the obliques may be at fault or the causative factor, but it need not be always. Patients with no oblique overaction with pattern strabismus may also can have this pattern strabismus, where the horizontal or vertical recti even may be the causative factor. So which may be due to anatomical alterations in their insertions of the recti. So this is another postulation. Demer et al. Demonstrated that there are compliant pulleys of collagen and elastin around each rectus muscle at the equator. And these compliant pulleys, they act as the functional origin of the muscles, and an ectopia of this pulley at the equator of the recti muscles. Because of the ectopia, that could be the reason for the pattern strabismus. And another thing we may say is, patients who present with V pattern esotropia, they tend to have their lateral canthi higher than the medial, which we call as the mongoloid facies. Whereas in V pattern esotropia, they tend to have their lower canthi lower than the medial. That's the anti-mongoloid facies. That's another thing which you may come across. And the most important thing in pattern strabismus, because when you start the treatment planning, evaluation, it's in any squint, for any case for that matter, evaluation is important, but it is more so because unless you have a definite idea of what is happening to the extraocular muscles, you cannot plan the treatment. So the patient should be evaluated for pattern strabismus in all the 9 directions of gaze using prisms and alt-in-cover test with distance fixation at chin elevated 30 degree, depressed 30 degree, and in primary position. And more on the clinical features evaluations will be dealt with by the subsequent speakers. Thank you.
Thank you, sir. Now over to Dr. Chaitanya for the next talk.
Good morning all. I am extremely thankful to Dr. Sasnaman sir and KSOS for giving me this opportunity. I am going to discuss the clinical features of pattern strabismus. As already sir discussed, when a horizontal deviation patient or even an orthophoric patient comes to our OPD, when we measure squint in different gazes, if there is a relative difference in the measurement in up gaze and down gaze, it's suggestive of a pattern strabismus. And when we plot these measurements in a paper from up gaze, midline primary position and down gaze, many times it will resemble many alphabet notations. So the other name is alphabet pattern. Common alphabet patterns like V, A, Y, lambda, X, diamond, and arrow. Few points from history. In 1897, Devans noticed V pattern in bilateral superior oblique palsy. Up-gaze and down-gaze measurements was popularized by Uretz and Savella. A and V pattern was suggested by Uretz. And coming to the pathogenesis, Knapp proposed oblique muscle dysfunction being the most common etiology. Coming to the clinical features, when a patient with either exotropia or esotropia come to our OPD, and when we measure the deviation in all gazes, and especially when there is a difference, gross difference in up-gaze and down-gaze. If for an esotropic patient, if there is a relative convergence in down-gaze compared to the up-gaze, suggestive of a V esotropia. And same way, if for an exotropic patient, if relative divergence in up-gaze compared to down-gaze, suggestive of an V pattern exotropia. When will become this V pattern significant? The difference between up-gaze and down-gaze measurement, if more than or equal to 15 prism diopters, this V pattern is significant for the further management. Usually associated with inferior oblique overaction or superior oblique palsy or other malformations. Same way for the A pattern, for an exotropic patient, if there is relative divergence in the down gaze, is suggestive of A pattern exotropia, and if relative convergence in the up gaze, suggestive of A pattern esotropia. When is this A pattern significant? If the difference between both up gaze and down gaze measurement more than or equal to 10 prism diopters, this A pattern is significant. Usually associated with superior oblique overaction or infantile strabismus, craniofacial malformation, Down syndrome or meningomyelocele. The other common pattern is Y pattern. Here the horizontal deviation remains same from down gaze up to the midline, and there is a relative divergence in the up gaze. Usually seen in bilateral inferior oblique overaction, Devans or Brown syndrome. Lambda pattern is the opposite of the Y pattern. Relative divergence happens in the down gaze, usually seen in overacting superior obliques or bilateral underacting inferior rectus, probably after a large recession surgery or slip muscle after surgery. X pattern is relative divergence both in up gaze and down gaze, usually seen with type 3 DRS or long-standing exo cases. Other patterns are diamond and arrow. Also, we should see the pseudo patterns. Pseudo V esotropia is seen in accommodative esotropia with uncorrected refractive error. And intermittent divergent squint can manifest as pseudo exotropia. Sometimes hydrocephalus or plagiocephaly manifests pseudo A pattern. Coming to the pathogenesis, the cause usually lies between peripheral mechanism and the central. Central cause is between the loss of fusion or abnormal fusion due to abnormal torsion mechanism. Peripheral cause lies between the three group of muscles and the pulleys and orbital anomalies. Oblique muscle dysfunction being the most common theory proposed by Knapp. Here the abduction being the tertiary action of oblique muscle is the culprit. What happens when the primary or secondary overaction of inferior oblique leading to increased abduction in elevation? For example, when inferior oblique overact, superior oblique will underact along with the elevation and abduction, there will be a relative divergence in the up gaze. Horizontal muscle dysfunction was another theory proposed. Here the imbalance of horizontal muscle forces was added as cause of pattern strabismus, but electromyographic study do not support this hypothesis. Cyclovertical muscle dysfunction is a less accepted theory. Muscle pulley dysfunction is another common factor. Here the extraocular muscle pulley heterotopy can lead on to vertical incompetence. Anomalies of muscle pulley can result in slippage of the ocular muscle during globe rotation, suggested by Demar et al. Clark et al. Suggests by even a small mislocation of less than 2 mm of the pulleys is significant. Orbital anomalies, craniofacial abnormalities, hydrocephalus, craniofacial syndromes all can contribute to the pattern strabismus. Neural factors, the theory lies between the loss of fusion with abnormal torsion. All these theories proposed by Miller and Guyton, Piper et al. All these relays between the loss of fusion and torsion mechanism. For example, in an excyclotropic patient, superior rectus will act as an elevator along with an abductor. and inferior rectus will act as an adductor also. Horizontal muscles, medial rectus will act as a partial elevator and lateral rectus will act as a partial depressor. This will contribute to a V pattern in a excyclotorsion. Coming to the clinical presentation. The clinical presentation varies based on the type of the strabismus and the amount of squint. Patient can present to you with ocular deviation or intermittent transient diplopia due to loss of fusion in certain cases, or sometimes asthenopic symptoms in cases of a pre-presbyopic group, especially in the down gaze, or sometimes compensatory head postures. Compensatory head postures can be chin up or chin down based on different patterns. How we will evaluate a pattern strabismus patient? Definitely we need to do a full refraction. Then the deviation should be measured in all 9 gazes, and the deviation in primary, up gaze and down gaze should be clearly measured, especially with a full correction of the refractive errors and for distance. Near to, it is always advised to do for distance measurement because to avoid the accommodation in the near measurement. 25-degree up gaze and 35-degree down gaze is advised. Also see whether there is any over elevation or over depression in adduction to rule out the obliques overaction or underaction. Binocular function should be seen and the ocular torsion should be ruled out by a dilated indirect ophthalmoscopic examination and orbital imaging in selected cases. What is the clinical importance of pattern strabismus? For all horizontal strabismus, we need to detect and measure whether a pattern is there. If so, we should look for what is the etiology because it will help to modify the surgical procedure and to plan the surgery ahead. Sometimes for larger deviation, we may need to go for a 2-step procedure. Thank you.
So, thank you, Chaitanya. So, Chaitanya was telling us about the clinical features of IV pattern strabismus. And now Dr. Rashmi from Pediatric Ophthalmology Clinic, Chaitanya Trivandrum, she is talking on 2 things. One is the essential principles in the management of pattern strabismus and the management of pattern strabismus. Tackling the obliques is also an important thing. So, she will be dealing with tackling the obliques also in her talk. And over to Dr. Rashmi for her 2 talks, which she has combined as one.
Good morning. First of all, let me thank Sahasraman sir and KSOS for giving me this opportunity. I have combined my 2 talks as a single one. So let's see what is the principle in the management of pattern strabismus. Pattern strabismus is not rare when one looks for it. It is difficult to manage than pure horizontal strabismus. A and B pattern will be seen in 15 to 25% of the horizontal strabismus. So, the basic principle is when you are planning for a correction, you have to divide the patient into 2, those with oblique dysfunction and those without, and a selective surgery to reduce the horizontal deviation in primary position and also to minimize the AV incompetency. The horizontal muscle shift works well when there is no oblique dysfunction. Primary and reading positions are functionally most important, and the results of the surgery can be unpredictable. So the patient workup, as Dr. Chaitanya has already told, abnormal head postures, measurement of deviation in up gaze and down gaze, and also in all 9 gazes. The overaction and adduction, that is very important because you are planning surgery according to it, that is inferior oblique overaction or superior oblique overaction, that is the overaction and adduction, the hypo or hyper should be evaluated. Torsion, which can be tested by double Maddox rod or by disc picture, that is more reliable criteria than an inferior version testing in case of overaction of the obliques. And orbital imaging is a must before surgical planning in case of craniofacial anomalies. Coming to the management part, as we all know, the first thing is to correct the refractory error if any and correction of the amblyopia. Just because you have diagnosed a AV pattern doesn't mean you need to do surgical correction in all the cases. It needs to be done only if significant or symptomatic in the direction of largest deviation. So what are the indications for surgery? To improve and maintain the binocular single vision, they correct the abnormal head posture and motor alignment. The surgical management of AP pattern can be divided into 2, with oblique dysfunction and without oblique dysfunction. First, we will be dealing with without oblique dysfunction. The horizontal muscle shift is a thing that you do when there is no oblique overaction. The maximum offset is 7 millimeter, and you move the muscle in the direction you wish to weaken them. As we can see in the acronym MAIL, medial rectus should always go towards the apex or closed end, and lateral rectus should always go to the empty space, that is the open end. So horizontal muscle shift was first described by Knapp. Is it easy to perform? Then you do oblique muscle surgery. Useful for smaller pattern, you shift half to one tendon width, and half tendon width shift will correct around 15 to 20 prism diopters. You can combine it along with the recessions or resections. The amount of recession and resection will depend upon the deviation in the primary case. The only problem is it can sometimes induce torsion if you done in unilateral cases. In case of A esotropia, if you are planning for a bimedial recession, you shift the medial rectus upward. And in case of B esotropia, you shift the medial rectus downward. If you are planning for a recession resection, in case of A pattern exotropia, the lateral rectus will be pushed down and medial rectus pushed up. And in B pattern exotropia, the lateral rectus will be shifted up and medial rectus will be shifted down. Then another procedure is the slanted recession, which was described by Boyd in 1971. In case of V esotropia, the slanting recession with greater recession of the inferior muscle insertion of medial rectus. And in A esotropia, more recession of the upper end. So wherever you want to more weakening, you recess, that part will be kept posteriorly. The vertical rectal surgery with horizontal displacement of insertion, that is superior and inferior rectus shifted medially or laterally, it was described by Miller. It affects the adducting force of recti but not routinely done. Now coming to my second part, that is tackling of the obliques, especially in cases of AV pattern. As we all know, the inferior oblique overaction usually causes a V pattern and a superior oblique overaction causes an A pattern. And they coming first to the inferior oblique surgery. The common weakening procedures are myotomy or myectomy, recession, anterecession, anteronasal transposition, and extirpation and denervation. Here myotomy and extirpation and denervation are not routinely done. The inferior oblique surgery, how will you approach it? Infratemporal incision is made, and from 8 millimeter from the limbus, you make a cut in the conjunctiva. Perpendicular incisions are made in the tendons to expose the bare sclera. As you can see, by careful dissection, and then the obliques are visible, you hook under direct visualization. Coming to the myectomy, after hooking the muscle, you take 8 to 10 millimeter of the muscle part is removed, you clamp it, you cut the muscle part, cauterize and leave it. Large V pattern corrects about 40 prism diopter when done bilaterally. In case of unilateral superior oblique palsy, it corrects around 15 prism diopters of hypertropia. The inferior oblique recessions, various recessions are described. Fink recession is 6 millimeter posterior and lateral to lateral rectus. The new insertion is kept there. Park is 8 millimeter recession where the inferior oblique is placed 3 millimeter behind and 2 millimeter lateral to the lateral part of inferior rectus. Elliott and Nankin has described different levels of recessions at the level of inferior rectus or anterior to it. And andropositioning is mainly indicated in case of DVD along with an inferior oblique overaction. This is a video showing the inferior oblique recession. We have hooked the muscle just I have shown before. You clamp the muscle close to the insertion. Now the muscle is clamped after hooking close to the insertion, and you cut the muscle and secure and clamp before taking the sutures. Usually in horizontal strabismus, you place the sutures and then you cut. Because the insertion comes close to the macula, it is always safe to cut the muscle, keep in the clamp, and then you place the sutures. Now the two sutures are placed 6-0 vicryl on either side, just like you place in a horizontal muscle surgeries. By doing this, you will avoid injury to the surrounding structures. Your muscle is secured in sutures, and you mark the position, that is 3 millimeter behind and 2 millimeter lateral. In the sclera, marking is made. And you take the scleral bites and the muscle is secured in position. Always before cutting, you make sure that you hook the lateral rectus as well as the inferior rectus, and you visualize the procedures and do. Now the muscle is secured in position and you tighten the sutures. After tightening, the conjunctiva can be closed with 8-0 interrupted sutures or continuous sutures. Now the various graded recessions, as the muscles are placed anteriorly, you get a more weakening effect, and various other procedures like antronasal transposition and nasal transposition has also been described. Inferior oblique anteriorization is done when you are seen along with DVD. The muscle is placed anterior to inferior rectus. This is a postoperative picture of a child who had a DVD along with an inferior oblique overaction and a large V pattern. Inferior oblique advancement has also been described for A pattern esotropia. Here you are disinserting the inferior oblique and passing it under the lateral rectus and attaches to sclera 2 to 3 mm superior and 8 mm posterior to the lateral rectus. Now coming to the superior oblique surgeries. Two types of surgery are there for the V pattern. You do, in case of superior oblique palsy, you can do a superior oblique tuck, and in A pattern with the superior oblique overaction, you do a weakening procedures. Superior oblique tenotomies you do in case of A pattern will correct the large A patterns. Around 25 to 45% diopters are corrected, and tenotomy close to the origin will have more weakening effect, and there is no significant alteration in the primary position. Posterior tenectomy of the superior oblique, the posterior fibers are cut, where the anterior fibers which are involved with torsion are preserved. It has a weakened abducting function, and it has less chance of producing a superior oblique palsy, and chances of but undercorrection is there. This is a video by my friend Dr. Soumya from Shankara, Bangalore. This is showing a superior oblique posterior tenectomy. Supratemporal incision is marked, and the conjunctiva is cut, and careful dissection of the tenons is made, and you first hook the superior rectus muscle. The superior rectus muscle is hooked and isolated, and underneath you can see the superior oblique which is hooked after carefully done. See, now the superior oblique has been hooked, and the tenons are separated. And after separating and isolating the superior oblique muscle, the anterior fibers are important, because if anterior fibers are cut, it can result in intrauterable torsion, and anterior fibers are left and the posterior part of the fibers are separated. See, the posterior fibers are separated and the posterior tenectomy is done. This is done commonly in case of A esotropia as well as A exotropia due to superior oblique overaction. See, the tenotomy is done. And now the conjunctiva is closed. Silicone expanders, here also the amount of weakening can be altered by the length of expander. 4 to 7 millimeters, 240 as band is placed. The advantage is reversible and there is less chance of overcorrection. Superior oblique tuck is done in case of congenital esopalsy with a lax tendon. If you are very sure the tendon is very lax, you can do a superior oblique tuck and it corrects the V pattern because of the lax tendon. Coming to the management of V esotropia, we know that if it is due to inferior oblique overaction, you weaken it, and if there is no overaction, then you do a bimedial recession with infra placement. Inferior oblique weakening alone and will correct 15 to 25 prism diopters. Vertical shift will correct around 20 to 25. Superior oblique tuck 15 to 25 prism diopters, and it along with an inferior oblique weakening will correct around 40 to 50 prism diopters. And V exo also the same thing, vertical shifting and inferior oblique will correct 15 to 20 around, and it along both combined together will correct around 30 prism diopters. And A esotropia, if it is very less than 20 prism, better to leave it alone. If more than 40 prism, you can do a superior oblique weakening, and if there is no overaction, then you do a bimedial recession with a vertical offset. A vertical offset will correct 20 to 25 and tenotomies will correct around 30 to 40 prisms. And A exotropy also same wise, and vertical shifting will correct around 15 to 20, while in case of superior oblique tenotomy is correct 30 to 40 prisms. Now the rare pattern strabismus management, Y pattern, here you can do a superior transposition of the lateral rectus And X patterns, if no oblique overactions are there, you do a recession of the lateral rectus alone, and in lambda pattern, you can weaken the superior oblique muscles. Complications of the pattern strabismus surgery as such, it can cause iatrogenic vertical and torsional strabismus and diplopia due to that. Persistence of overaction will be there. Sometimes esopalsy if you do a superior oblique weakening. Abnormal head posture you induce with due to the torsional strabismus, and anterior segment ischemia, and vertical can be multiple vertical muscles are involved. This is an algorithm showing the AV pattern what we have told. Thank you.
Thank you, Rishmi Madam, for the excellent talk. Now I invite Dr. Kaushik Murali Sir for the keynote address.
Good morning. At the outset, I would like to thank KSOS and Dr. Sahasranam for inviting me to be a part of this session. It always is a pleasure to come back to the Kerala conference. The warmth and the camaraderie that you see here, you don't often see in most other ophthalmic meetings. It's always a pleasure to be back here. Again, before I start my presentation, I would like to acknowledge some of my colleagues who contributed towards some of the videos and pictures that I would be showcasing as a part of this. I acknowledge Dr. Saumya, Dr. Nishant, and Dr. Kavita, who helped me put together this. What I'm going to be sharing with you is trying to make sense of twists and turns that we see in terms of anomalous head postures in children. Again, the intention is not to scare you, but we also understand that this is something that every ophthalmologist may come across in their clinic. And when you come across this, what can you practically do, or what can you do in your own setup, is what we are trying to walk you through. So first, to start off, you need to understand that torticollis, or any twisted posture, comes from this combination of two words, tortus and column, which literally translates to twisted neck. So when you look at any eye condition leading to an anomalous head posture, we refer to it as ocular torticollis. So whenever a patient derives advantage by adopting it, it may actually make more sense for us to call it as a compensatory head posture rather than as an ocular torticollis, because there is some functional improvement that the child or the adult actually undertakes. So that is something that has been suggested earlier, but we will stick with ocular torticollis for the basis of this presentation. So again, a child who has a twisted head or a torticollis may do so because of ocular conditions, because of inner ear conditions, or due to some issues in the entire muscle spindle. And what you need to understand is that anomalous head posture is not a diagnosis, but rather is a sign of some underlying disorder. And as ophthalmologists, I think we need to spend a little bit more time in trying to identify what the potential cause could be. Now, when you look at the eye in a torticollis, again, you need to understand that the head may, or the face may be tilted in three potential directions. So it could be around the x-axis, where you have a little bit of a turn. It could be around the z-axis, where you have a little bit of a face turn happening, and along the y-axis, where you have a chin up or a chin down happening. So let's just look at it one at a time. Now, how do we measure it? There have been various devices that have been created to measure this, that have gyroscopes, that have magnets put. But the simplest way to do it is to use a scale and a protractor, or use an orthopedic goniometer with a protractor and measure it. So here we are actually measuring a face turn. So if you look at it, you're looking at the rotation of the anterior posterior axis from the normal position that is there. So you just keep the protractor perpendicular, and then you measure out on the scale, saying that how many angles has the face actually been turned. Next, when you're looking at the chin up or the chin down position, so here you keep one arm that is perpendicular to the fixation target. So you ask the child to look straight ahead, and with the other you align it with the anterior posterior axis of the skull. So that again gives you in terms of angles as to how much up or down the child is actually keeping their face. Head tilt becomes a little tricky, because again there is some amount of parallax, you're standing behind the child. But here again the key is to try and keep it perpendicular to the floor, and the other arm you align it to the axis of the face, and again you can get a reasonably good, reliable, repeatable kind of a measurement by using this very simple device that all of us would have access to. So the Taylor and Hoyt textbook of pediatric ophthalmology carries this lovely table that kind of encapsulates what all potential conditions can be. The reason I put it here is that not all torticollis is necessarily because of the eye, and not all torticollis can you blame it on musculoskeletal anomalies. So it could happen because of trauma, it could happen because of certain congenital issues. Of late, practically, I'm seeing a whole lot of children where the parent will say that the child turns his face when he's watching TV. We've done refraction, we've broken our head, we've sent him for an MRI. Finally, what you realize is the child has wax in one ear. He's not able to hear clearly, and he turns his head actually to the ear that he can hear better. So now as a protocol, we almost tell every parent saying that, have you put Solivax or Vaxolil in the child's ear? Otherwise, next time you take him to the pediatrician, please get the hearing tested. So that is something that we found as a hack that works in a number of children, especially from a non-ocular cause. Skeletal anomalies, muscular paresis, all of these can cause certain issues. These largely would fall under what are the non-ocular. Among the ocular, again, we'll come back to it. The most common, which all of us can handle, continues to be actually refractive errors. We often forget that refractive errors can cause an issue, visual fields can cause an issue. A drooping of a bilateral ptosis could make the child take a chin-up position. Then, of course, you have other issues like paresis, restrictive strabismus, and other mechanical restrictions that could come into play. And sometimes there also could be a congenital torticollis. So invariably, whenever we find a finding, we get kind of obsessed with it as clinicians and try to dive very deep into it. A torticollis or an anomalous head posture, the first thing that we need to do is to look at the person as a whole. So in this child, it looks like he's having a chin up. Probably if we gave it as a spotter, lot of us would say probably he has a bilateral ptosis and that's why he's doing it. But when you look at the entire body, it is very obvious he's got a skeleton anomaly that makes him adopt that kind of a peculiar posture, and you cannot do anything as an ophthalmologist to correct it. So all we need to do is refer him to an orthopedic surgeon. So we need to look at the child as a whole. The next question comes saying that you need to figure out saying that is it ocular, non-ocular. The simplest way to do it is ask the child to close their eyes and hold the head straight. So and try to kind of move the head in one or two random directions with their eyes closed. If they're able to maintain it, then probably it is non-ocular. That becomes the simplest way of kind of classifying whether it is ocular or non-ocular. Now the next question then comes, okay, we figured out it is ocular, is it one eye or two eye? So here if you look at it, we are occluding one eye, the AHP remains, and slowly you occlude the other eye, the AHP will continue to kind of remain in the girl that you see here. But when you look at the boy on the other side, the minute you occlude one eye, you will notice the AHP kind of marginally get better. But when you occlude the other eye, it almost completely disappears. So it's very clear that that is an AHP where one eye is involved, whereas here you have both the eyes involved. So that way, algorithmically, you can arrive at what is happening. Now, an AHP can happen in a variety of ocular causes, right from strabismus, nystagmus, to refractive errors and field defects. Why does this happen is again very simple. It will happen if the child can actually improve in their visual acuity or binocularity. AHP in a child indicates that there is functional vision possibly in both the eyes, especially in infants where you see a tilted head. You can relax a little bit. That means the child is possibly using both the eyes, and to maintain binocularity is why they are adopting that particular posture. It is very rarely seen following vision loss in one eye, where to obviate diplopia, the child adopts a posture to actually take it away from the fusional range. That has been reported. I have not seen too many of these conditions. Again, that is something that back of the head we need to remember. To reiterate, ocular torticollis is driven by the need to optimize visual acuity, to maintain single binocular vision, and to center a narrow field with respect to the body. So this becomes especially important in terms of nystagmus children. So in any child, the first thing to do is to correct the AHP and observe. The minute you correct the AHP, the squint becomes very obvious. So you know that you're going to be handling a possible strabismus in the girl. And in the other one, you need to check ocular movements. You can use a toy, you can use a fixation stick, you can use pretty much anything that can attract the child's attention. Something with sound works well. A smartphone with a small video playing is also as effective as an object for you to check ocular movement. So you can play a cartoon of YouTube and attract the child's attention. So that works really, really well. So once you check the ocular movements and figure it out, then arrive at some kind of a possible diagnosis. So in this particular child, you've done a kind of you've arrived that it is binocularly driven by the previous things. You've looked at the ocular movements, and with that you can then arrive at a diagnosis of it being a possible left superior oblique palsy. So in any of these strabismus conditions, what you need to remember is the head will move to where the eye cannot move. So that is the simplest way for you to figure out, saying that which possible muscle is affected or what range of movement is affected, by just looking at how the posture is maintained. That can help you, because what the child is attempting to do is to avoid diplopia. In infantile nystagmus, again we know that there is something called as the null zone. The null zone is that position in gaze where the nystagmus is dampened, and with the nystagmus becoming dampened, the visual acuity automatically gets better. So in this case, you will notice that the face turn kind of dampens the nystagmus. I apologize, the video is small, it may not be very evident. But whenever this null zone is not in the primary position, you will see children with nystagmus keep their face straight. So that probably is because the null zone is in the primary position. Whenever it is not in the null zone, they will adopt an AHP. They will adopt an AHP not all the time. So when they're talking to you, they may not. But when they have to actually use their vision, when you ask them to read a distance vision chart, is the easiest way for you to elicit that potential null point that will kind of be triggered by the AHP there. So this again is obviously not a child, but I put this here because again it's one of a very interesting case. So it's very clear, this is a right face turn, but when we correct his posture, eyes are straight. And this is a patient who does not have nystagmus. Now you are kind of confused, saying what the hell is going on. So in this patient, whenever you see such a condition where you correct the posture, you don't see a nystagmus, you need to do a visual fields. So here what do you see? You see a very clear homonymous hemianopia. So when you put both of this together, you need to understand that the face turns towards the defected side with gaze, and it is usually towards, it gives a preference to the contralateral side to the field defect, or it is ipsilateral to the field defect. So why this does is because this adaptive posturing that the patient undertakes expands his useful peripheral field. So by turning his face, he is making sure that he is able to turn his eye to the side that he can see better. So that again gives you some idea. So wherever the head posture gets corrected, you don't see a nystagmus or a squint. As ophthalmologists, please get a visual fields done. That will probably give you a clue as to what else is happening there. Again, the most common thing that we see in most children is something that we should not forget. A majority of anomalous head postures or compensatory head postures continue to be because of refractive errors, and that is something very, very key. So this child had this extremely gross error. The minute you put a pair of glasses, almost miraculously you see the head go straight. So the first thing that we need to do in all of these children is to refract them and make sure that they have an appropriate correction. So face turn again is most common in myopia and against the rule astigmatism. Again, just putting a simple pair of glasses will help correct it. Head tilts happen. Now most of us will have a small cylindrical power that allows us to see a little clearer, and we don't correct it. But take a simple trial frame that is there and just twist it around with the target. You would see the kind of change and distortions that happen. So whenever the visual axis does not coincide with the optical axis, if the prescription is very weak, the child will turn their head to fixate through the peripheral part of the lens. Because look at that schematic on top. The minute it goes a little bit of an off center, pretty much for every few millimeters, it adds in a lot of plus there. So the child will struggle to see even if a plus lens is offset, because it then induces a prismatic effect. So that becomes very important for the child to be able to focus very clearly. So look at this girl. She's got a frame that is tilted. She's correctly prescribed. So this is how she would see. So we just pulled it out and took an image. Now obviously she's not going to be happy looking the way the image on the right is. She's going to adopt a face turn. And this is something again you'll very commonly see. Place a frame on your table. You will find one part of the frame completely lifted up. The other thing that we also see very often with a lot of the lenses getting fitted is they come in 60 mm blank. So they just cut it out and put it to the center of the frame. That may not be centered to the optical center. So the minute you see a child where you provide glasses, still the child is tilting the head, the first thing to do is figure out whether the frame is okay. Second, check for the optical centration and check whether that is all right. If that is not all right, that becomes something that we need to do. A chin up again gives an advantage of a stenopic slit, and again you see it a lot more common in both myopia and astigmatism. Correcting glasses again helps you get that corrected very well. A chin down has been reported in moderate hyperopia because it is thought that there is some divergence that is physiologically there, and it kind of increases the amount of accommodation without convergence that would be there when the child is looking in the primary gaze or in the down gaze. So that kind of helps the child to over accommodate in a sense and cover up some part of the hyperopia that the child has. So again, any hyperopia in a child with the chin down position preferably should be corrected. So to sum up, to make our life very easy, first thing first, figure out what is happening, figure out whether it is an ocular or a non-ocular anomalous head posture, whether it is binocular or uniocular, and then start getting into action. You don't have to look for a specialist. Correcting a refractive error is something every one of us in this room can do. Getting the visual field tested is something that every one of us can do. We need to understand that the child is adopting it probably to gain visual acuity, binocularity. Looking for nystagmus is something very, very simple. And even after we correct it, if we find certain things, then is where you need to do a cover test, look for the ocular movement. So don't hassle yourself saying that, oh my God, is this a V pattern, A pattern, what is going on? Keep it simple, do the stuff that you know that you do routinely, and then we can try and help these children see better. So once again, I thank you all very much for this opportunity.
So thank you, Dr. Kaushik, because it's a very, very sort of very tricky situation because the parents are very much concerned. It's because of the cosmetic problem it produces, and to evaluate an abnormal head posture, no, it's a very, very difficult situation. So unless you are thorough with what is happening in ocular causes of AHP, it needs an algorithmic approach to evaluate it, and that was and your talk was very, very, very elucidating. So thank you for accepting our invitation and be a part of this session. And now the session is open for discussion. Any questions we can have?
Sir Kaushik, sir, one doubt. When we come across infantile nystagmus syndrome, where there is no refractive error and the child is adopting a very significant face turn, and when you see that the face turn is alternating, how do you approach such a case whenever you are planning a surgical correction like doing a modified Anderson?
So early part of our careers, all of us have been super aggressive, trying many things, and we burnt our fingers. So once you see a variable face turn, it is prudent to wait and watch for a longer time, because quite often the child is also trying to figure out the actual null point. And there will be certain cases of infantile nystagmus where there is no obvious null point. So trying to dampen it is not very this thing. We've tried brimonidine eye drops, we've tried other ways of trying to dampen it. Again, we've not found it to be very effective. Sometimes masterly inactivity works the best. Like the basic principle of the Hippocrates oath of do no harm is, I think, something that we need to remember and understand our limitations where we are doing it. But if at all you are intervening, it would make sense to tell the parent that there is a possibility that the child seeing right may actually see left next. I've seen a couple of our children go that way, and that we may have to undo some damage by re-intervening or giving some prisms. Older children, sometimes giving Fresnel prisms helps, because you can explain to them that it is a temporary thing. It looks a little ugly, it looks a little shabby because it has, you can see those striations on the glass, but at least there is some insurance of saying that it's not permanent.
Okay.
So
No, right now masterly inactivity only, I'm just asking. Thank you, sir.
So if there are no other questions, I think we'll wind up this session, and I request all the speakers for a group photo, and I request CV Radha Madam to come forward to give this memento to Dr. Kaushik Murali.